In the fall of 2025, Essilor Stellest lenses became the first US spectacle lens proven to slow pediatric myopia progression. And if you're like me, you really want to figure out how to best incorporate this into clinical practice, in your optometry practice. You may have seen the news, absorbed the information, and now you're like, all right, I'm ready to rock and roll. If that's you, stay tuned for this podcast. It's exactly what we're going to talk about. Hey, everybody, it's Dr. Ryan Corte, and welcome back to another episode of Ryan Reflects. It's 2026, and we're going to hit the ground running with something that has been one of the biggest wins in optometry in 2025. And if you're like me, though, you may have taken some time to try to best implement the new Essilor Stellest lenses into clinical practice. And so you're building out policies, procedures, you're working through how are you going to communicate this to patients? How are you going to communicate this to parents? Because it's really the parent and guardian who are signing off on it for the little ones who are going to be prescribed these lenses. And then you're trying to figure out the best management fees, the best pricing for the lenses, the best possible way that you can track this information over time and provide care to our pediatric patients that are myopic and are candidates for the lens. And so I personally have spent a lot of time kind of diving into this and refining this for my practice, Reflect Vision Care. And I'm excited for you to kind of hear some of the steps we've taken, but also I'd love to hear in the comments what you're doing to best implement Essilor Stellest lenses into your clinical practice as an optometrist. Hey, but if you're new here, I would love to ask you a quick favor. Make sure that, of course, after you listen a little bit, that you take the moment, the time to hit that like, subscribe, follow button, leave a comment. That just shows a signal to the platform that you're listening on or watching on that you're getting value out of today's content and the content that I'm delivering. And that's my promise to you, to continue to drive value for optometrists, innovative, thought-provoking content, and also engaging in conversations with our peers to drive the profession forward. So back to Essilor Stellest lenses. These lenses have been available outside the United States for a little while, right? I mean, we have peers in Canada who have talked about their success, but just as of last fall in 2025, Essilor Stellest lenses became the first US spectacle lens proven to slow pediatric myopia progression. And if you're listening and you're like, well, why are we tackling myopia now? Myopia has been along for a long period of time. Why are we doing it now? The reality is myopia is a disease process, right? It's not just a refractive inconvenience based off the data anymore. I mean, we're seeing a rapid rise in prevalence in little kiddos, meaning they're at a greater risk for lifelong ocular complications. And to me, that kind of hits home. You know, I had LASIK, but I'm around a minus 450 in regard to pre-LASIK measurements. I did jump from like a 150 to a 250 to a 350, all the way up to about a minus 4.5. And my wife is close to about a minus 6. And so, you know, we're keeping a close eye on our kiddos. But the reality is about 36.6% of the global population today is myopic. And as we approach 2050, nearly half of the world's population may be myopic, right? That's a lot of people. And if you think about it, the school-age kiddos that we are getting in for comprehensive eye exams before they get into school each summer or even throughout the year, well, this prevalence can exceed 40 to 50% in that school-age category. And we want to really do our best to halt the rate of progression of myopia. We can't stop it entirely, right? We can't reverse what's already happened, but there's a lot of data behind let's really control and manage to the best of our ability the rate of progression of myopia. So what are some risk factors? Well, as an optometrist, you know this, but just a simple kind of recap here. Mom and dad have it. Hey, you have a higher risk, right? 2 myopic parents increases the risk 3 to 6x. 1 myopic parent roughly doubles your risk. So Amelia, Brody, sorry, mommy and daddy have myopia. We have to keep a close eye on you. And of course, the earlier on that it's detected, you know, the closer eye you want to have on it over time. So really want to be proactive, get into these schools, get in and have conversations with administration, nurses, teachers, do outreach, do the best that you possibly can, though, to get in our school-age children, elementary school and middle school, even preschool, get them in as early as you want, get them in for that infancy 6-month eye exam and do the best you possibly can. Myopia beginning before the age of 10, well, it's strongly associated with higher lifetime progression. The earlier the onset, more years of axial elongation, higher risk of higher myopia, right? So degenerative myopia, not what we want to see. So being proactive, absolutely key here. But what about screen time? What about, just putting in all of these extended hours on laptops, cell phones, tablets, mommy and daddy's devices. These kids are getting their hands on devices at such an early age, and extended near time tasks, about 2 hours a day, can increase a little one's risk. Smartphone, tablet use, my kids, we limit their screen time on tablets for about an hour a day using the Amazon-based tablets. And honestly, we could probably even cut it back a little bit more. But the truth of the matter is that that's just that tablet. And then they may have access to screens at times, like watching TV, shows, grabbing the phone and just playing on it. And who knows what they're doing when they're together with their peers as they get older and older and they have access to devices. But this continuous near work without breaks, not ideal, right, for these little ones. What's a preventative factor? Being outdoors more, right? Children who spend, at least an hour and a half, 2 hours outside a day, that can be a protective factor. If you're spending less than that outside a day, let's just say less than an hour and a half or an hour, not ideal, right? So outdoor time is inversely related to both onset and progression. And these are things that we can be talking to parents about, right? And of course, there's other factors that can put little ones at risk. Just the overall background of the family. We tend to see myopia really rampant in certain areas of the world. East Asian children show earlier onset and higher rates of progression. But current trends are continue to push the envelope here in the United States, regardless of background. And baseline refractive error, right? These pre-myopic profiles predict a higher likelihood of transitioning to myopia. So, that lower amount of hyperopia at that kindergarten age tends to kind of take off a little quicker. And of course, we want to be mindful of parent education. We want to be mindful of all these factors, but I think the take-home message is, risk factors can compound. And, a child with early onset, 2 myopic parents doing a lot of screen time on tablets, cell phones, digital devices, maybe not spending as much time outdoors. Well, they're at an increased risk for starting off and hitting the ground running with myopia. And so what can we do, though, as optometrists, as eye care professionals, to incorporate myopia control, myopia management into our clinical practice, in particular Stellest? And I'll just walk you through a little bit of what we're doing at Reflect Vision Care. So first and foremost, what exactly is Essilor Stellest lenses? It's a lens design with a central clear zone and then rings of aspheric lenslets, creating this peripheral myopic defocus. It's using what's called HALT technology, 11 rings, a little over 1,000 lenslets, and that there's like a central 9 millimeters of a clear zone. I'm actually, if you're watching the video, I'm holding up a little Essilor Stellest box here, and inside of it, there is the lens, and I use this as an educational tool in clinic. And so you can kind of see the inside of the box right here with the Stellest logo, a little bit of information on, and it may be hard to totally appreciate the lens. Just a visual, not information, but a visual that you can use for parents. And then, of course, the lens itself. And it's hard to really appreciate. I'll put my hand behind it to see if we can get some of these lenslets in better vision, focusing with the camera. But the reality is, this tool, when I'm able to show it to parents and they hold it up to the light or they put it right in front of their own eyes, it does give a great visual before actually getting the patient over to optical and then fitting and prescribing and moving forward with purchasing Stellest lenses. But indication is a slow myopia progression and correct for myopia in nearsighted children with or without astigmatism. A huge value add, right? Because some of the other tools in our toolbox, some of the myopia management soft contact lenses like MySight don't necessarily meet the criteria once you hit a certain amount of astigmatism, if you're masking astigmatism. But to me, it just provides an effective glasses-based treatment option for younger children or families not ready for contact lenses. I feel like it's a nice little low barrier to entry option that rounds out what we have available. And so love that. And I also love what the data is showing, that the 2-year randomized clinical trial, about 71% slower myopia progression and about 43% slower axial elongation versus single vision, and long-term results 3 to 6 years sustained about 57% slower refractive progression and 52% slower axial elongation. So one of the most effective spectacle-based myopia control options globally. And again, FDA approved in the United States. A huge stamp of approval and honestly something to give us confidence when having conversations with parents, because you'll have parents that when you present this as a treatment option, they're going to look at you and be like, well, myopia has been something that's been out there for a very long period of time. Why treat and halt this progression now? But we have data now to back it up. The why behind really treating, we want to reduce our risks overall of a retinal detachment. You got a 3-time higher risk when you're between -1 and -3, almost 9 times higher risk between -3 and -5, almost a 20 times higher risk of when you're 6 diopters or more. I mean, right there, to me, if we've all taken care of patients, we've all treated and triaged patients that have had retinal detachments, not a good situation, right? Not an ideal situation. Ideally, we're able to catch it early, we're able to catch it with the macula on. But if we can reduce the overall risk of that, why wouldn't we? Especially for these individuals who are myopic and they're little ones, and we can actually really reduce their rate of change. Maybe go from a -1 to a -250 instead of going from a -1 to a -6 over their lifetime with myopia control. Also, myopic maculopathy or myopic macular degeneration. We don't really see that in emmetropes, but the rise dramatically increases, right? We start to see this more in our patients that are -3, -4 and up over time. And one of the fastest growing causes of irreversible central vision loss, more long-term trajectory, but we've all seen patients that are extremely myopic and they have macular stretching and they have maculopathy and they're at an increased risk of just degeneration of that region. Glaucoma myopes have a 2-time increased risk. Moderate to high myopes may even approach 3 to 5 time increased risk. Cataracts myopes showed 2 times increased risk of PSC and cataracts. And the reality is that if we can squash the risk of all of these different disease states, why wouldn't we? Right? I mean, we as eye care professionals, why wouldn't we do that? Why wouldn't we have that conversation and position that to our patients as a treatment option, especially with all the data that has come out now, and especially with 2 FDA-approved options in the United States with Stellest lenses from Essilor and MySight contact lenses from CooperVision, and I'm sure many more to come. And so when you take all that into consideration and you take into consideration just in general, when you think about increase in axial length, kind of elongation of the eye, and just all of how that can impact the retina and the posterior segment of a patient long-term, this right here is a no-brainer to me. And so let's talk a little bit about kind of where Stellest fits in myopia control or management treatment protocols. Of course, you want to get your staff, your team highly educated. You want to get yourself highly educated on the product and have them, and of course yourself, identify high-risk candidates and start to identify individuals and families that you can have this conversation. We all have patient bases of our own. We can run searches and reports in these EHR systems to identify, specific age ranges, specific prescription profiles, and you may already have a nice little patient base that you can send information out to via email or text about this new treatment option, and see if they come in and ask about it from there. Of course, as you're going through, though, on your day-to-day patient care journey, identify patients in the chair. Have your staff go ahead and flag them during the patient workup process if they see that they have their little one and they are a little bit nearsighted, or they've been nearsighted, or they wear glasses that illustrate they're nearsighted. Their autorefraction comes back a little bit nearsighted. Have them star it, right? Have them star the intake form, have them star their chart, have them put a note in the chief complaint section of your EHR. And then, of course, you're going to want to run some basic, baseline testing, a cycloplegic refraction. You want to measure axial length. You'll get, a complete comprehensive exam, posterior and anterior segment evaluation, binocular vision, and then you're going to position it accordingly in your clinic. But I strongly recommend, and this is something that we did in our practice, we have a myopia management consent and treatment agreement. And within this agreement, what it does is it essentially has a QR code and it links to our website. And that QR code is a educational article for parents. And so I'll just read this to you so you can hear some of the information that we contain in this consent and treatment agreement. It says, I acknowledge that my optometrist has explained the available myopia management treatment options for my child, including which option may be most appropriate. And I have had the chance to ask questions and discuss any concerns. I also reviewed the parent resource provided in the QR code below. I understand the following: the risk and benefits of treatments described above, the costs associated with myopia management, and they're not covered by medical or vision insurance. The goal of treatment is to slow the progression, not to stop it completely. A very key and important thing to point out to parents. And the results may vary from child to child and cannot be guaranteed. Of course, there's a compliance portion to this. Compliance portion isn't noted in here. Maybe I could add that. And that some treatment options have FDA approval for vision correction, but may not yet have approval specifically for slowing myopia progression. And then we kind of go over each individual option. So Stellest lenses, which are FDA approved, my MySight soft contact lenses, FDA approved, orthokeratology, and low dose atropine. The last two are not. And then we go over our global management fee, as well as what the fees are for either the lenses or whether it's the Stellest lens or the MySight lens, the cost of orthokeratology, and the monthly cost for low dose atropine eye drops. And at the end, it says, I understand while treatment aims to slow myopia progression, no method can guarantee results. And it's the truth, right? And we're looking to overall reduce the risk for these individuals, but nothing is bulletproof. And when you look at the clinical studies, the number needed to treat to actually have an impact, well, it varies based on clinical treatment, but nothing is perfect. And again, we're looking to halt progression, not to reverse or completely stop myopia. But some evidence is based on younger children or specific prescription ranges, but older children may still benefit from myopia control as well. That's all put in our myopia management consent and treatment form: the child's name, the parent's name, signature, practitioner's name, date, and of course, QR code. And if you go to reflectvisioncare.com and you look at the blog, you can see some of the articles we have along this to educate our parents, right? And the primary one is on myopia management. And then it breaks out into individual resources for each treatment option. But I found this to be, extremely impactful for our clinic. Not only is it a resource and a tool that we're utilizing to educate our team, because we're educating our team on all four options, but also the parent, the guardian of the little one. And it's a resource that they can continue to come back to. It's digital. It's driving in traffic for people that are searching for myopia control or myopia management. And then, of course, we're having them sign off on consent, which is important. Now, I'm not an attorney. You want to run these kind of things past your legal counsel to make sure that everything is buttoned up for your particular practice. But I do recommend that you have some kind of agreement, some kind of consent treatment form, walking through the overall risks, the benefits, and what you're doing, right? The services that you're offering here, because this is a specialized service. And so another thing that I think is important for us to really consider as optometrists is how are we going about charging for our time? And also, are we bundling in certain fees and with the prescribing of Stellest lenses? So for me personally, we have a global management fee that the patient will pay and will sign off on the prescription. And then, I'm located adjacent to Lens Crafters, so they can fill that prescription at their trusted optical retailer. And then we already have the patient back in our practice, scheduled out 6 months from the time that they are seen in our practice. So we're able to do a follow-up at that time. We're taking axial length on our patients right at that time as well. So they're opting into a global management fee that covers follow-ups, inquiries, questions, testing during that period of time for that service. And I've also seen practices actually doing some research and talking to peers where they're bundling it into the cost of the lenses. Some practices are saying, hey, here's the cost for the management fee, here's the cost for the lenses. You got to figure out what works best for your practice and kind of go from there. I'll be honest, it really truly depends on where you practice, how you practice, what your partnerships look like, on how you're going to go about doing so. But we have an annual global myopia management program fee for all 4 treatment options. And it's worked out extremely well thus far. I mean, we've really spent a lot of time in the last 3 to 6 months building out our myopia management clinical guidelines and clinical practice. And we're going to continue to double down on that in 2026. But if you're somebody who's been rocking all treatment modalities for a long period of time, and this is just kind of the icing on the cake, because we have too, but we've dabbled a lot, if I'm being honest. We haven't done a ton of MiSight or a ton of Ortho-K or a ton of atropine. I think Stellest was kind of the icing on the cake to really get excited about a very easily accessible treatment option to even pair with some of the other options, right? You could do Stellest lenses and MiSight contact lenses. Something to be excited about. You could also possibly pair it with low dose atropine. Again, no studies support that, but why not look into it and consider it? And I'm sure somebody out there could start doing a little bit of research and clinical studies on that. But best practices: define what's included, document thoroughly, avoid improper insurance bundling, and then separate routine exams for program visits. So, the overall routine exam that's going to be taking place in your practice, that's billed under the comprehensive eye exam for the patient. And then this could be is a additional global service fee annually in our practice. But you have to figure out, how are you positioning it? How are you identifying candidates, educating parents, charging for your time, charging for the product, and then building that out in your practice. So some pearls, the reality is myopia is not going anywhere. It's been around for a very long period of time. What we're gathering more and more information, more and more data on the risks of myopia and becoming more and more nearsighted, especially based on all the risk factors of having more than one parent, having 2 parents that have myopia, not spending a lot of time outdoors, spending more time on digital devices, and all these things and more are just going to continue to compound. And so they're putting our little ones at risk for not only just mild myopia, but moderate to severe myopia, which comes with increased risks of ocular sequelae down the road. But it's important to have these conversations with parents. It's important to also understand, hey, like if we're prescribing this, you're wearing these glasses all day long, right? And you're going to be following up based on the follow-up cadence that we provide you. And this is something that you're really partnering with the parent. In our practice, we have began to start taking axial length measurements because it's important, right? And axial length is one of those key metrics to continue to monitor over time, of course, with refractive error. We're showing parents the lenses in clinic and just what they look like. And then we're doing our best to track compliance and provide more data so that we can help fight this together. The pitfalls, of course, you want to make sure that you're not saying, hey, we're stopping myopia, or that we are completely reversing what's already happened. In my opinion, kind of look at it like glaucoma. When you're treating and managing glaucoma, what's done is done. We're trying to kind of squash any kind of change over time. And so that's incredibly important when communicating it to your patients. But if I leave you with kind of my final thoughts on this, I feel like as a profession in optometry, this is a huge opportunity for us to improve our patients' quality of life, really to be intentional with our pediatric patients, our school-age patients, and to get out into our communities and to kind of preach about myopia control, myopia management, and reducing the rate of change of these little ones who we've identified are myopic and at risk for myopic complications down the road. It's a suite of services that we can provide in our clinic, with Essilor Stellest lenses being the newest of those options and FDA approved. And of course, with Essilor Stellest lenses being kind of the low barrier to entry to prescribe glasses to little ones who may not be a candidate for contacts or don't always want to have to put drops in their eyes. So I absolutely love the opportunity at hand here. And my ask to you is to let me know in the comments your thoughts on how you're going about and putting into clinical practice the treatment, the management, the prescribing of Essilor Stellest lenses, any kind of clinical pearls, wins, losses that you've had. And of course, we'll continue this conversation as we gain more traction, data, and information. But I'll leave you with this. I have fit a number of patients in this product so far. It's so far so good. I've not had any back for a 6-month follow-up because it hasn't been FDA approved for 6 months yet. But I have seen a few back that just wanted to have the glasses evaluated by the optometrist, not the optician. And absolutely love what I'm seeing. Of course, it's unique, it's different, and it will take some education on the front end, a lot of education on the front end, depending on the family. And it will take some adaptation for the little ones. But I'm truly excited to see where this goes in my practice, but really in our profession, and how we can elevate and raise myopia management to the next level as optometrists. So that's all I have for you today. Again, if you haven't liked, subscribed, commented, followed, please do. And stay tuned for my next podcast where we can reflect and grow stronger together.